Hello, I'm Dr. Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple, and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. We really do appreciate that. Now, you can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups, and you can also visit gpnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings, which occur all year round. Now, in this episode, I'm going to be discussing two neurological emergencies that, although they're relatively rare, do demand an immediate recognition and response: conus medullaris syndrome, or CMS, and cauda equina syndrome, CES. Now, these conditions, arising from adjacent regions at the lower end of the spinal cord, do share many clinical features, and so are frequently mistaken for one another. But my focus of this podcast, though, is primarily on cauda equina syndrome, as this has not only been requested by one of our GP listeners, and many thanks for that great suggestion, but is also the more commonly encountered of the two and often presents first in primary care. Now, as GPs, our role is not just important, it's often decisive, and the early detection and rapid escalation of these syndromes can significantly influence patient outcomes. Unfortunately, delays in diagnosis still occur and can result in devastating lifelong neurological impairments. So this is one of the reasons I wanted to talk about cauda equina syndrome today, in order to help us recognize the warning signs, navigate the diagnostic process efficiently, and respond correctly. First, though, let's briefly go back to our medical student days learning anatomy. Now, the spinal cord, as you know, terminates in a cone-shaped structure called the conus medullaris, typically located at the level of the L1 vertebral body in most adults, and this marks the end of the spinal cord proper. From the conus, a bundle of lumbar and sacral nerve roots descend into the lumbar cistern, and these are collectively known as the cauda equina, rather fancifully named for their resemblance to a horse's tail. These nerve roots then exit at various levels to innervate the lower limbs, bladder, bowel, perineum, and pelvic organs. So damage to the conus itself typically results in conus medullaris syndrome, and this may cause bilateral, symmetrical neurological deficits and features of both upper and lower motor neuron lesions due to the involvement of the spinal cord and peripheral nerve roots. In contrast, injury to the cauda equina nerve roots, being purely peripheral structures, leads to a lower motor neuron syndrome, often asymmetric, with flaccid paralysis and areflexia. Now, understanding this anatomical distinction is important, but from a clinical perspective, the presentations often overlap considerably. And unfortunately for us, patients don't walk into our consulting rooms with labels on them telling us their spinal pathology, and differentiating CES from CMS can be difficult. Fortunately, the urgency of investigation and treatment is the same in both cases. Now, CES can be classified, and it can be classified as incomplete CES, sometimes called CESI. And here, there's thecal sac compression with subjective symptoms such as a loss of desire to urinate but no retention, and objective signs of CES. There can be CES with retention, or CESR, where there's thecal sac compression with established neurogenic urinary retention and overflow incontinence. And there can be complete CES or CESC, where there's complete loss of all cauda equina function, absent perineal and perianal sensation, and a patulous anus. However, I always advise my junior doctors to be cautious regarding classifying CES, as there's often poor agreement between clinicians when trying to do so, and in practice this should not alter the urgency of our treatment. Now, both syndromes are relatively uncommon. CES has an estimated annual incidence of between 1 and 3 per 100,000 of the population. Now, that figure on the surface of it may seem small, but it becomes more clinically relevant when we consider that approximately 2% of all patients with a lumbar disc herniation will go on to develop CES. Now, given how frequently we see back pain in general practice, and some estimates suggest up to 30% of all GP consultations relate to musculoskeletal pain, this statistic should alert us to the fact that CES is not simply a hypothetical risk, and most of us will encounter at least one case during our professional careers. Now, I've actually seen a number of cases and remember each one vividly, not just for the clinical features, but for the speed with which intervention was needed and the consequences that could have arisen if it had been delayed. So, herniated lumbar discs do remain the most common underlying cause of CES, accounting for nearly half of all cases. And the pathophysiology here involves the mechanical compression of nerve roots within the thecal sac, typically due to a large central disc protrusion. But obviously, we must also bear in mind other possible causes. Epidural abscesses, for example, particularly in immunocompromised individuals or those with a history of intravenous drug use, are increasingly recognized here. Epidural hematomas, whether spontaneous, traumatic, or post-surgical, may also result in acute compression, and spinal stenosis, vertebral fractures, metastatic spinal tumours, and inflammatory or infectious processes such as discitis or osteomyelitis can also all precipitate CES or CMS. There are also iatrogenic causes to consider, including complications of spinal surgery, lumbar punctures, and, although these are rare, vigorous or inappropriate chiropractic manipulation. Less frequently, vascular anomalies such as AV malformations or aortic occlusion may compromise blood supply and so indirectly cause spinal cord or nerve root damage. So, I'm going to turn to clinical presentation now, and this is where things get slightly nuanced. Patients often present with lower back pain radiating into one or both legs, and this pain may be long-standing or it may have developed acutely. And sciatica is nearly always present in CES, but it may be unilateral or bilateral. And early symptoms can be subtle. There can be a change in urinary habit, some slight numbness around the buttocks, or a vague feeling of weakness in the legs. Now, what makes this condition particularly challenging is that these symptoms can be intermittent or slowly progressive, and many patients have already been told, sometimes repeatedly, that they have a slipped disc or non-specific back pain. And it's our job as GPs to remain alert for evolving or cumulative warning signs. Now, as we know, the red flags we should always look for include urinary dysfunction, and this may present as hesitancy, poor stream, or new onset retention. And often patients will describe a feeling of not being able to fully empty their bladder or a loss of the normal sensation of needing to void. Sexual dysfunction, altered perineal or perianal sensation, the so-called saddle anesthesia, and motor weakness in the lower limbs are also significant indicators. Now, while these symptoms individually might be attributed to benign causes, their simultaneous presence, particularly if they've developed recently, should always raise a strong clinical suspicion. And I think it's also really important to appreciate that CES does not follow a predictable clinical trajectory. Some patients will deteriorate rapidly over hours, whilst others report symptoms evolving over days or even weeks. And moreover, there's a significant inter-patient variation in which symptoms appear first. So a patient may come to us with nothing more than an odd numbness in the inner thighs or a little bit of urinary hesitancy, but by the next day they may be incontinent. So from a clinical standpoint, perineal sensory loss and bladder dysfunction are particularly diagnostic in my view. If you have a patient who reports numbness when wiping after a bowel movement, or they've lost the ability to feel when they need to urinate, you must always take these symptoms seriously and investigate them immediately. So when we were examining our patient, the findings in CES typically include asymmetric lower motor neuron signs, such as flaccid paralysis, hypotonia, reduced or absent reflexes, and muscle wasting in the lower limbs. Perineal sensation should be tested systematically, as should anal tone, and a rectal examination may reveal a patulous anus or loss of the bulbocavernosus reflex, which both indicate disruption of sacral nerve function. Now in CMS, signs may be more symmetric, and upper motor neuron features such as spasticity or hyperreflexia may be present due to direct involvement of the spinal cord, but these distinctions can be blurred, especially when pathology spans both the conus and the cauda equina. Now, we've obviously got to always consider possible differential diagnoses, haven't we? And the list here is fairly extensive. So non-compressive causes of spinal cord dysfunction include things like transverse myelitis, spinal infarction, MS, HIV-related myelopathy, and syringomyelia. And all these conditions may mimic CES or CMS, but they typically lack the mechanical compression seen on imaging, and they also may show distinct cerebrospinal fluid or inflammatory marker findings. So accurate diagnosis depends on thorough investigation, including imaging, blood tests, and sometimes a lumbar puncture. So I just want to pull all this together because we've covered quite a lot already. And I would say suspect a cauda equina syndrome if a patient presents to you with leg pain and or back pain, together with onset in the previous 14 days or deterioration of any of these 4 red flag symptoms. 1. Disturbance of bladder or bowel function, and sensory changes are particularly significant. 2. Altered sensation, such as pins or needles and numbness around the perianal, the perineal, or genital areas, the so-called saddle areas. 3. Motor weakness or other neurological deficits affecting both legs. And 4. Sexual dysfunction. So, given the stakes that we know of here, the diagnosis of CES must be made as quickly and accurately as possible, and MRI is the imaging modality of choice, offering detailed views of soft tissue, nerve roots, and spinal cord structures. And I have to say, ideally, imaging should be arranged immediately upon suspicion. Delays of even a few hours can lead to worst outcomes. Although, interestingly, over a third of requested scans for CES show no evidence of cauda equina compression. If for any reason an MRI is contraindicated, CT myelography can be used, although this is more invasive and technically demanding. Ultrasound can also provide valuable adjunctive information in the primary care or emergency setting, particularly through measurement of post-void residual bladder volume. And a volume greater than 200 mL after voiding strongly suggests urinary retention and should prompt urgent spinal imaging. Now, once CES is suspected, the next step is immediate referral to a spinal surgery or neurosurgical service, and here time is truly of the essence. Surgical decompression, typically by laminectomy with or without discectomy, should ideally occur within 24 to 48 hours of symptom onset at most. Outcomes are significantly better when surgery is performed early, although this doesn't guarantee a full recovery. Now, the British Association of Spine Surgeons and the Society of British Neurological Surgeons Standards of Care document for CES does state that nothing is to be gained by delaying surgery, whereas there is much potentially to be lost, and that emergency surgical decompression must take place at the earliest opportunity for all patients with imaging-confirmed CES. Bladder dysfunction at presentation is the single greatest predictor of poor long-term outcome, regardless of surgical timing, but early intervention does remain the best chance for preserving function. Unfortunately, despite timely and appropriate management, many patients will experience ongoing symptoms, and persistent urinary retention, sexual dysfunction, and things like saddle anesthesia are common. The extent of any long-term disability closely correlates with the severity of neurological impairment at presentation and the rapidity of treatment, and outcomes are worse for patients with painless urinary retention and or overflow incontinence than for patients with incomplete Cauda equina. I'm sure it'll come as no surprise that any delay for surgery with patients, it's likely to adversely affect prognosis. Now, some patients develop chronic pain syndrome and ongoing bladder, bowel, or sexual dysfunction, as well as pain, leg weakness, and sensory loss have been reported in up to 60% of people after surgery. So recovery may be incomplete and prolonged, so patients should be managed with realistic expectations, and they require ongoing multidisciplinary support, including physiotherapy, urology input, and sometimes even psychological counselling. So just to pull all this together now, both Cauda equina syndrome and conus medullaris syndrome represent medical emergencies with potentially devastating consequences if misdiagnosed or treated late. As GPs, our ability to recognize early red flags, arrange urgent imaging, and initiate prompt referral is absolutely crucial in preventing lifelong disability. These cases are rare, fortunately, but when they do arise, they demand clinical vigilance and decisive action. So listen to the patient carefully, examine them thoroughly, and escalate without delay when your clinical instincts are raised. These are conditions we simply can't afford to miss, and I do really hope you found this podcast helpful about them. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.